So our learning objectives today are to learn some of the nomenclature related to seizure activity, recognize some abnormal EEG activity on the polysomnogram, and be able to respond to a patient having a seizure in the sleep lab safely. So what I want you to consider is for yourselves is, what is a seizure? What is epilepsy? If anybody wants to hazard a guess, most of us, please speak up. Most of us have probably seen somebody having a seizure, whether it's at a public pool or a mall. It's quite frightening. It's unusual. The behaviors are atypical. But how would you describe a seizure, epilepsy? Are they the same thing? Are they different?
I think of a seizure as abnormal discharge of neurons. And I think technically epilepsy is, seizures without a specific etiology or unknown etiology, but sometimes I think they are used interchangeably, seizure disorder and epilepsy.
Yeah, most people do use these terms interchangeably. Seizure definitely is an event associated with abnormal brain activity and is demonstrable by abnormal behaviors. And then epilepsy really is the condition that is the tendency to have recurring unprovoked seizures. So just to give you the difference in those terms and how they should be used, epilepsy really is the syndrome, somebody who has seizures that happen quite frequently, repeatedly. Seizure itself is the one event. So, somebody might have a seizure, but they don't necessarily have epilepsy. Sort of give you a historical perspective of the examination of seizures, or what was understood about seizures. This is a painting of called the Priestess of Delphi. And Pythia was the priestess who held court at the sanctuary dedicated to the Greek god of Apollo. And this was a position of honor that was held from the 8th century to the 4th century BC. She was revered as an oracle. She would be possessed by Apollo and come up with prophecies while steeped in these dreamlike trances and seizures. And epilepsy was considered to be a possession by Apollo. Now, of course, we suspect that there's a more organic reason why Pythia was having these seizures. They were burning oleander fumes, and oleander poisoning is some of the symptoms you might expect are tremors, drowsiness, ataxia, visual disturbances, and seizures. So we know there's an organic reason why Pythia was having these seizures. But it really was known as the sacred disease in antiquity, and this notion prevailed for centuries, even after Hippocrates expressed his opposition to that. And Aristotle, interestingly, considered sleep itself as a form of epilepsy. Okay, so we talked about what seizures are, what epilepsy is. Seizures are changes in awareness or behavior brought about by abnormal discharge of electrical activity in the brain. Epilepsy, as we said, is the tendency toward recurrent and unprovoked seizures. The prevalence of epilepsy in the US is about 1.2%, in Canada about 1, so very similar. About 20% of patients with epilepsy will have seizures during sleep. 40 will have seizures only while awake, and 35% will have both. So it behooves us as sleep technologists and sleep physicians to learn something about seizures, because patients in the sleep lab will definitely have some, patients with epilepsy in the sleep lab will definitely have the possibility of having a seizure while we're examining them. The prevalence of abnormal EEG recordings is estimated, and it ranges somewhere between 4 and 50%. Some of the patients that we see who have very severe epilepsy, the whole record might be abnormal. Some patients who have been diagnosed with epilepsy and they're on some medications, sometimes I don't see any abnormal EEG at all, just maybe an overall qualitative change in the EEG. Okay, so the association between epilepsy and sleep. Sleep disorders definitely are more prevalent in the epileptic population. Again, why we should learn about them. Nocturnal seizures usually occur towards the end of the sleep period between 5 and 6 a.m. Fortunately for us, chances of capturing seizures in the lab are low, even in patients with known epilepsy. I've only seen really a handful of true seizures, what people think of as seizures. I'm sure there are very small seizures that have abrupt arousals that resolve themselves very quickly and only last a few seconds that might go missed. But in terms of a big full-on uncontrolled seizure, I've seen very few of those. And of course, one reason why we want to be identifying these is they can result in pretty long central apneas in the case here. You can see on C4 and O2, the abnormal activity starts right about here, and there's quite a long central apnea with a significant desaturation into the 70s. That could pose a life-threatening event, of course. Okay, so the first part of it we'll discuss is EEG abnormalities. As we said, not everybody with an EEG abnormality has epilepsy, and not everyone with epilepsy will have an abnormal EEG. The background EEG in patients with epilepsy is usually normal. And what distinguishes them is abnormal interictal EEG manifestation. So interictal is a word meaning between the seizures, so not during the seizure, but between the seizures. These may include non-epileptiform abnormalities, but one thing that will be spending particular attention on today is interictal epileptiform discharges, IEDs. And we'll talk about how to recognize those, what they make up in a bit. So patients with epilepsy may show generalized focal slowing of the background EEG, but this is the most useful diagnostic finding supportive of epilepsy is these IEDs, whether they be focal, which is in one part of the brain, or generalized, which is across the whole cranium. And I'm not going to spend a lot of time on benign variants today, but IEDs must be carefully distinguished from benign variants. We probably do a whole talk on benign variants, and maybe we will one day. Of course, artifact or even normal brainwaves to avoid overinterpretation. So what actually is abnormal on the EEG? It's interesting, I find that most sleep technologists, there is a chat message here. I don't know if somebody has a question. Oh, somebody was answering my question. Thanks, Andy. I missed that one. My question to you again is, what is abnormal activity on the EEG? As sleep technologists, we're trained and physicians, of course, nurse practitioners, if you're out there, anybody else, we're trained to recognize normal features on the EEG, spindles, K complexes, slow waves. Before I came to SickKids, I got exactly zero training on how to recognize abnormal activity. I think that's a bit of a dropped ball in terms of education for sleep techs. I think it should be part of the whole spectrum of what we are trained in. And of course, down in the States with a changing business model towards home sleep testing, there is there's a drive to cross-train sleep technologists for their own preservation in the field. Because of course, if we're doing home sleep testing, there's going to be far fewer jobs doing actual sleep studies. So if you can get training as a sleep tech in abnormal EEG and learn to recognize those things and maybe work in a lab that specializes in doing both EEGs and polysonograms, that's a possible future career path for us. Anyway, so what is abnormal in the EEG? Usually we're the most recognizable one. Oh, there's a couple chats here. Spike and wave on the EEG. Thanks, Barry. That's right. Spike and wave activity. It may look like vertex sharp waves or K complexes or slow wave activity. Interictal spikes or solo spikes, which may look like muscle artifact. Ictal activity, that's during the seizure, is often obscured by muscle artifact. Rhythmic activity, which may look like the alpha rhythm. So let's look at some of these examples. So we have interictal epileptiform discharges. Those are between seizures. Those feature isolated spikes, sharp wave spike complexes. There is no behavioral change. And then ictal during the seizure, we have that behavioral change, and the EEG may contain spikes, sharp waves lasting seconds or even minutes. So recognizing seizure activity on an EEG can be challenging for sleep technologists and relates to a couple of factors: number and placement of EEG electrodes, the experience of the sleep tech. Certainly when I was a baby tech, I looked at hypnagogic hypersynchrony and I thought maybe that was a seizure. It's your, it's the experience of looking at EEG over many years that which really educates you. The size and location of the ictal generator, and of course the paper speed. So in sleep labs, of course, we're used to using the ASM montage, frontal, central, and occipital derivations. In EEG labs, they have a much broader spectrum of leads applied. And of course, it's makes up the double banana montage, so-called, which allows us to localize some of the abnormal activity. It's okay to use the standard ASM PSG. Normally, you will pick up global activity, of course, if they're very diffuse global activity, we're probably going to pick them up on all of our leads. But if we want to localize that activity, of course, the extended bilateral montage is what the ASM recommends for looking at paroxysmal arousal, sleep disruptions that might be thought to be seizure related. So you might want to consider putting a few more leads on if your lab is not doing that. The advantages of doing a PSG EEG, these IEDs are the most sensitive and specific marker for seizure diagnosis. Routine EEG studies only record for about 20 to 30 minutes. Of course, we're recording maybe 6 to 10 hours. So the chance of us recording some IEDs and perhaps even a seizure is quite a bit greater. And of course, if ambulatory EEGs are performed, they don't actually provide any information on the sleep disorder, like sleep disordered breathing. They might not even record oxygen saturation. So that's an advantage of us doing a PSG EEG. Of course, seizures can be triggered by OSA. OSA creates sleep fragmentation, creates seizures. There's lower seizure threshold. There's a kind of a vicious cycle. And OSA is quite prevalent in adults with epilepsy, with a prevalence rate around 40%, and moderate to severe in about 16%. So what's our role as a sleep technologist? Well, we're not going to be diagnosing patients with epilepsy, but we want to make note of any suspected abnormalities that we find in the EEG. We want to have the video available, look at it carefully, describe any patient behaviors. If you do see something happening, make sure you go into the room, ask the patient how they feel, whether they were aware of their behaviors or if they remember them. Of course, if it's a seizure, they likely will not remember them. And as Kevin was saying, in parasomnias, depending on the type of parasomnia, they may have memory of the event or not. So whether they remember the event is extremely important. Being able to know that you can change the time scale and use a slower paper speed of a 10-second window to really examine some of the abnormal EEG. So you may want to play around with the montage more than you're used to doing when you're looking for EEG abnormalities. So this is our little toolbox that we're going to use to describe what you see in the EEG: frequency, localization, amplitude, and variability. And if anybody knows what that stands for, Flavor Flav will bring that to your mind if you ever forget that acronym. So what is spikes? What are spike waves? All of those sorts of things. Let's talk about what the definitions of those waveforms are. So a spike is I still can't say this word, epileptogenic waves made up of spike waves and sharp waves. We have spike waves, the duration being 20 to 70 milliseconds, while sharp waves are a little bit longer at 70 to 200 milliseconds. And the joke is the shape of the waveform really indicates how spike-like it is. If it looks like it would hurt if you sat on it, it's more than likely a spike. And so we have monophasic to polyphasic spikes. Here's a comparison between sharp waves and spike waves and poly spikes at our 10-second per page speed, and then 30 seconds per page. And you can see it's a little bit harder to see what they look like when we're looking at it in 30-second epochs. So if you change that paper speed to 30 millimeters a second or 10 seconds per page, you can really examine the structure and see whether it's a spike or a spike wave complex a lot more easily. Okay, so interictal spikes, again, less than 70 milliseconds, usually associated with focal epilepsy. Here's some examples of some interictal spikes. Kind of almost looks like an EEG artifact, EKG artifact on the EEG. So that's one aspect you might want to play around with your montage. Drag the EKG signal up close to the EEG channels and make sure those QRS complexes aren't lining up with these potential spikes to identify whether they're artifact or not. Spike and wave, of course, the spike component of spike and wave activity still would be less than 70 milliseconds, but we'll have this nice slow wave following each one of these. And this is really characteristic and really jumps out at you when you see it on EEG. And we'll look at some examples of that in this particular sequence. One of the tools we're going to use is describing the frequency of these abnormal waveforms. And of course, we have 3 spike and wave complexes in this 1 second. So this is 3 hertz or 3 cycles per second spike and wave activity. This goes back to, I think, a question was posed of Manuela, how we would measure slow waves. One of the tools that we can use is the waveform cursor tool in our particular sleep software, SleepWorks, which I utilize on occasion. So we can look at waveforms such as this spike and this waveform, this slow wave rather, and we can see what the duration of this is. So if we zoom in a little bit on this, and we use our waveform cursor tool, click once at each trough, of course, as denoted by these little red and blue circles. We can see that, of course, the duration of this spike preceding this slow wave is 63 milliseconds. So that is less than 70, and therefore it compromises a spike. And of course, looks like if you sat on that, definitely would hurt. I certainly wouldn't do it. Here's a couple of runs of spike and wave activity on EEG. This is typical 3 hertz spike wave oscillation. Usually it's in the 2 to 4 hertz range. And in the second example, you can see some multiple spikes present before the slow wave component. Ictal discharges are a little bit different. You may see some spikes and spike waves, but typically behavior is the most important feature to examine during the seizure. And if the seizure includes movement, usually the EEG is going to be unreadable anyway. There might be some slowing after the seizure as well. So this is what the ictal discharge might look like. You'll see some possible faster activity building in amplitude and then slowing down during the event, and then ending towards the end here with 3 hertz spike and wave discharges. So why do seizures happen in sleep? Well, seizures are often strongly influenced by the sleep-wake cycle. Kevin was mentioning the ultradian cycle, and oftentimes there's an arousal, either before REM, during REM, after REM, and that change of state has an effect on the brain's epileptic activity. Nocturnal seizures are often triggered by changes in electrical activity in the brain while moving between different stages of sleep or between sleep and wakefulness. And that's, of course, why OSA is so problematic in this population. So most IEDs, most interictal discharges, will occur during non-REM sleep, and specifically during N1 and N2, less so N3. And then most sleep-related seizures occur in N2, as you can see here in the graph. This is the number of seizures occurring. About 70% of seizures that occur in sleep occur in stage 2 sleep. Interestingly, REM sleep has a protective effect against seizures. There are very few or no IEDs. There are very few no seizures that occur in REM sleep. As we saw in our graph right here, the graph is essentially nil for REM. It seems to limit the spread of epileptic discharges outside the area that started electrical activity. I'm not an expert on EEG, but it does have to do with the synchronization of EEG during N2, specifically in N3. But somebody smarter than me can speak longer about that. I'm not going to read all of these. This is more of just a reference for you, how to recognize a seizure. Things that are happening in sleep that are unusual, clusters of jackknife movements. If they sit up, some dazed behavior, muscle jerking of the arms, legs, or body. Again, if you're asking them how they feel, you can, did you see anything? Did you smell anything? They might remember that, they probably won't. If there's sudden fear, anger, panic, or no reason, again, differential diagnosis from night terrors, if there's a seizure, it can look very similar. We see a lot of these different types of patients. You probably aren't seeing these in private labs. I'm not going to go into all of these. I will spend a little bit of time talking about a case study with a generalized tonic-clonic seizure that we saw. Just a little bit about BECTS, benign childhood epilepsy with centrotemporal spikes, which used to be called Rolandic. I see that quite often. We do see a lot of patients with Lennox-Gastaut and Landau-Kleffner syndrome, but I'm excited about one case I want to show you is that frontal onset seizure, nocturnal frontal lobe epilepsy, which is quite rare. I actually captured what I think to be one of those in the lab last week. So that's another case that I'll share with you. So the first one is generalized tonic-clonic seizures, and this is what people usually think of when they think of a seizure happening, as I mentioned, maybe at the mall or at the neighborhood pool. I guess I'm dating myself. People don't really go swim in public pools at the park anymore. But anyway, you'll see the tonic component in which the limbs stiffen and the body becomes rigid. And then there's a clonic period. After that period of stiffening, the limbs and face begin to jerk rhythmically. There may be a loss of bowel or bladder control as well. And then afterwards, you'll have confusion, fatigue, and headache. And of course, the person would be unlikely to remember anything that was occurring during the seizure and probably would be a little bit upset. So here's an example of a generalized tonic-clonic seizure in a 25-year-old man. So we have, this is the tonic phase, so it's the initial phase. At the onset, there's low voltage rhythmic beta activity, which increasingly progresses in amplitude and slows down. And then during the ictal event, towards the end, the EEG activities are largely obscured by muscle artifact. The more recognizable part of the seizure is towards the end, during which the ictal discharges are changed to periodic spike and wave, which we know how to recognize now, and also are contaminated by a little bit of muscle artifact. And then following this period of spike and wave discharges, oftentimes you'll see the EEG is suppressed or even completely flat. The term for this is burst suppression. It's actually quite scary to see if you've ever seen it, because you kind of freak out and say, oh my God, this EEG is flat. Is this patient like dying? There is a chance they will die during this period. There is an increase, what they call SUDEP, S-U-D-E-P, sudden unexplained death from epilepsy phenomena. I think that's what it stands for. And it is increased during this post-ictal suppression period. So it's very important to watch patients during this period. Of course, there's hypoxemia. If there's, I showed that long central apnea as a result of the seizure. So there might be hypoxemia and hypercapnia during this period that will exacerbate that. Okay, so our first case study is a 15-year-old male with generalized epilepsy, diagnosed with intractable seizures, developmental delay, autism, nephrocalcinosis, presented in infancy with West syndrome, on a variety of anti-epileptic medications, Topamax, Zerontin, clobazam, vitamin B6, which is also used as an anti-epileptic. He was referred to us for snoring, gasping, pauses in breathing overnight, daytime sleepiness and fatigue, unable to stay awake during the day recently, and more frequently in naps. So he was initiated on APAP in the community, which is actually interesting because it seems to be happening more and more with our older patients. At lights off, again, interestingly, the technologist has noted the lights have to stay on during sleep onset due to seizures. So there is a photosensitive component. Some individuals with epilepsy that feature seizures that have a photosensitive component, seizures might be triggered by bright flashing lights, or in this case, even just the turning off of the light. So the EEG, if we look at it, it's quite high in amplitude. These two bars here are guidelines to denote 75 microvolts. You can see the patient's awake. They're still looking around. Overall high chin muscle tone, quite high amplitude EEG. As they fall asleep, chin muscle tone goes down. We start to see some slow eye movements. And two, we have nice spindles, K complexes. So far, so good. So far, so good. And then bang, we start to see things that look like they would hurt if we sat on them, right? So spiky activity here and here and here. And over here as well. Okay, if we change to 10 seconds per page, those waveforms are in fact easier to see. You can see a nice spike waveform right there. And also right there. And if we're looking for our friend Flavor Flav, we can use him to analyze some of these. So our localization, we're going to look at which channels the EEG is maximal on. So it looks like the central channel here is maximal in both derivations. So it's generalized diffuse, looks like it's occurring all across the head, occipital, it's being picked up on central, and maximal on the central derivation. REM sleep, of course, as we said, looks fine. No IEDs, nothing going on, nice low chin muscle tone, rapid eye movements. So the night goes on, patient is sleeping peacefully, he has good ventilation, 19/12, which is pretty high, but looks like he's tolerating it. Lo and behold, airways closed. So the unit is actually trying to breathe for him, trying to push these breaths in, but you can see it's just auto cycling right now. He's not triggering the unit at all. His airway is closed and there's quite significant desaturation here, causing a number of arousals. This is probably an untagged arousal right here. So what do we know? Well, sleep fragmentation does cause seizures. So, what happened here? Let's look at the EEG first, and then we'll look at the behavior. So how can we describe this EEG pattern? Well, it's a little bit hard to see right here. So let's change to 10 seconds per page. Well, it's a little bit easier to see. Again, let's play around with our montage. It's generalized, so it looks like it's across all of the channels, maximal in the frontal derivation. And if we isolate the frontal leads, you can see some nice spike wave. There's two spikes here and a wave, and so forth. And the frequency, about 2 to 4 hertz, right? There's 3, maybe 2.5 here, 4 hertz right here, 3 hertz here. So you can just count these spike wave complexes, 1, 2, 3. So any guesses as to what time of night this occurred? Anybody who's seen this before? I mean, I've shown this case before. Don't cheat. But anybody wants to put it in the chat? Any guesses what time this was? Or just unmute yourself. What time do seizures usually happen? Very good guess, Miriam. So let's get our answer. About 5:30. So we know that most seizures occur between 5 to 6 a.m. This one, of course, did happen between those hours. I just have to try and hide this chat window here. There we go. And of course, Flavor Flav. Yeah, boy! Hopefully that was really loud and woke you up at this point. We know what time it is. Okay, so let's look at a little video of, I hope this plays. It is currently not playing. Let me turn off my laser. Maybe that's the. There we go. There we go. Hopefully you can hear it. Should be able to hear the machine auto cycling. So there's a tonic component as we described. And And fortunately, the seizure did resolve. It didn't progress into the clonic, and then it didn't extend itself. I actually had one patient who had, Sonny can speak to that one. He was the fellow on call that night, who had uncontrolled seizure, and it progressed tonic clonic, which did not resolve itself. Fortunately for us, this patient did resolve, but that's the kind of behaviors to look for in patients who have seizures or tendency towards seizures. This one's not that interesting, and I don't have any cases on it, but just I wanted to mention this one because it's quite common. Benign childhood epilepsy with centrotemporal spike, so AKA benign Rolandic epilepsy. It's a focal idiopathic disorder, and most children outgrow it. That's why it's not really that concern, and why it's called benign, of course. Oh, I got to put my laser pointer up here. It starts about the ages of 3 to 13 with a peak around 8 to 9, and usually resolves itself in the teenage years. So what you'll see is centrotemporal spikes, so in the central and temporal regions, not recording on the temporal usually, but we'll see them on our central channels quite frequently. Usually few seizures and maybe only one experienced in their life, but they may feature altered speech, salivation, and syncope. And on the EEG, this is what it'll look like. So we can see, let's localize. So we're looking for centrotemporal spike. So if I can draw your attention to the spike and wave activity that's occurring on the temporal region, T3 here, C3, C4, that's where it's maximal, of course. So that's why it's called centrotemporal spikes. Again, not very interesting, but just so you know that can occur. Okay, so frontal lobe epilepsy, and this is the one we'll want to pay specific attention to in terms of differentiating it from parasomnias. It is quite bizarre in terms of the behaviors that are seen. Let's look at what the EEG might look like. So we have epileptiform discharges during wake in A, and then B in sleep over the midline and frontal region. So let's zoom in here. This is F3 and C3 derivation, FZ and CZ here, F4 and C4. You can see the spike and wave discharge is maximal in those regions. And then in sleep, actually, it's not as recognizable, just some spike activity occurring here. So this is a sudden awakening with violent movement, dystonic or tonic posturing, and hyperactive behavior. It might resemble a night terror or even REM behavior disorder. EEG may be normal, or it may show frontal slowing or spikes, cluster of short fits, and there's a rapid start on and off. You might see sudden battering movements during sleep. The head might jerk to one side, the upper limbs rising into a brief frozen state, and there may be some behavioral automatisms like rocking or even bicycle pedaling movements. Yes, the legs actually cycle up in the air like that. And you'll see some repetitive hand movements, which is the case I will show you. Features that. Only about a quarter of focal epilepsies. It's quite rare. As I said, when the EEG is abnormal, you might see frontal spikes or sharp waves, and they typically occur during sleep and are brief. I'm not going to play this video, and just in the interest of time, but I do want to make sure that you have this. So I assume these presentations will be sent out to you. But if you want to jot down that YouTube link, and if you're really interested, the word for looking at the behaviorisms during seizures is called semiology. And if you're interested in looking at a video of all of the different behaviors that can occur with different kinds of seizures from an actual expert. I'm not an expert. This is a pretty good one. Lawrence Vanderhoff at University of Alabama. The one quote he says, though, is, "The weirder it looks, the more likely it is to be a frontal lobe seizure." So let's keep that in mind. Oops, let's not play this. Let's keep that in mind when we look at our second case of an 8-year-old male with Dravet syndrome. 25 kilos, 128 centimeters, normal BMI. Symptoms of OSA and hypersomnolence. This individual sleeps 12 to 13 hours per night, but still awakens unrefreshed. And if you've never heard of Dravet syndrome, it's approximately 1 in 40,000 people losing it here. 1 in 40,000 people globally. It's also known as severe myoclonic epilepsy of infancy. It's rare and catastrophic form of intractable epilepsy, which means that it's only going to get worse, unfortunately. Initial seizures are generally prolonged, and in the second year of life, other seizure types begin to surface. The development is on track initially, but that plateaus, and there's usually a progressive decline beginning in the second year. And as I mentioned before, there's a high prevalence of SUDEP, so a sudden unexplained death in epilepsy. So the sleep history, in terms of the medications the patient's on, valproic acid, anticonvulsant, ethosuximide, also anticonvulsant used to treat absence seizures, bifenton, and Intuiv used to treat ADHD. PSG, as baseline assessment, was relatively normal. Kevin, I think Sunny mentioned the AHI for central apneas is considered normal at less than 2. 2.8, pretty normal. OHI, definitely normal at 0.7 per hour. Transcutaneous average 39, and the max was 45. Of course, did not tolerate end-tidal CO2. Okay, so let's look at our EEG findings first. This is N1 sleep in this individual, low amplitude mixed frequency EEG, maybe some slow eye movements here. Looks pretty normal. All of a sudden, N2, not so normal. So now that we know what spike wave looks like, these spike components definitely look like they hurt if you sat on them, and these slower components that follow are pretty characteristic as well. So as we've seen, it can be a tendency to look at these, oh, it's just slow wave sleep. Well, this is not slow wave sleep. This is abnormal activity, and we can look at it a little closer to confirm that. So if we change the montage, we can describe this pattern as spike and wave complexes. If we want to perhaps localize this, it looks like maximal on the frontal leads, right? This is F4 right here. This is F3. We're seeing it also on our occipital channel, but definitely predominantly on the frontal channels, which leads us to believe, well, maybe it could be a tendency towards frontal lobe seizures. Again, REM sleep, totally normal, low chin EMG, low amplitude mixed frequency, some rapid eye movements, no IEDs. And this is what his N3 sleep looks like. Lots of slow waves, some spike and wave discharges here and possibly here, and some more here, here, and here. And you can see how paroxysmal they are, even in slow wave sleep. They do jump out from the background. So I asked my neurologist fellow at Sick Kids if he would help me with the lingo here. And this is what he told us. We have generalized IEDs with bifrontal predominance. They're maximal in the frontal derivation. And we also see some diffuse, low amplitude multifocal IEDs. And the most interesting part will be this one. So this is just a few minutes. I've kind of compressed the time in the clipped out little snippets of some of the behaviors. You can see there's abrupt hand movements occurring there. You can see the spike and wave discharges here and here. More hand movements, lots of spike and wave discharges here, here, and here, some spikes over here. He's going to sit up and looks a little bit confused. And he's doing some rhythmic automatisms. Some body rocking that does not look to be purposeful. Spike and wave discharges, and then some rocking, more spike and wave here, more behavioral automatisms, spike and wave here, and the hand shaking and body shaking, and the confusion. Now, I really wish the technologists had gone in and asked this guy what if he felt okay, or what if he had memory of the event. because that would be a little more diagnostic of frontal lobe epilepsy. And actually, that's the fellow asked me, did anybody ask him what he was doing? No, nobody did. There's more shaking following some spike and wave activity. More shaking. Lots more spike and wave activity here, here, and here. Again, that doesn't look like he's doing that on purpose. I mean, we do see body rocking that is for comfort sometimes, some uncontrolled hand movements there. Lots of spike and wave activity here, 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 and here. And again, it doesn't look purposeful. It doesn't look like he's doing that on his own. Although it can be hard to tell, to be honest with you. Okay. And I think very shortly he's going to, this episode is going to resolve and he's going to lie back down. Lots more spikes here, spike and wave activity here, here. And that rocking. Yeah, this is when it resolves here. More spikes and waves, and of course, more body movements. Okay. Does anybody have any questions or comments about that? And if not, I'll ask you to describe the behaviors. Well, I mean, I kind of ruined it all by describing that, but maybe you could just think about how we describe them. The semiology, as I said, from the fellow, the way he described it was brief nocturnal stereotyped hyperkinetic behaviors. And he said it's likely to be a frontal lobe seizure in this case when we reviewed it. But we saw abrupt hand movements, rhythmic body shaking, movements do not appear purposeful. Oh, there's chats. Yes, it did take a long time period to resolve. But I think, oh, was it the parent speaking? I think it was the child speaking. Yeah, it did take a long time to resolve, and it wasn't the classic tonic-clonic seizure, so it wasn't necessarily a safety event. But as I said, I wish somebody would have gone in and asked him, should we do any interference? I will get to that, Ashraf. That's one slide that I have prepared for you, what to do when you do see a seizure. And perhaps we'll, if anybody has any other questions about this case or any comments, I'm happy to entertain them. But if not, we'll go on to what you should do when something like this happens. Oh, there's another chat here. Let's see. Yeah, could lead, exactly. We don't know if he's ever had any of those, but it is possible. Barry's comment is it could lead to a grand mal seizure in the old terminology. Now it's called a generalized tonic-clonic seizure. Definitely scary and can be a safety event in your lab. Absolutely. Yeah, Kevin says for everybody's benefit, parent could dismiss it as a child likes to dance in his sleep. If you didn't have any knowledge about what different movements look like during seizures, if you thought that it always had to look like a classic generalized tonic-clonic seizure, you might not know that it actually was a seizure. Absolutely. Okay, I think we've got about 15 minutes left. I'm going to skip this other case because it's not actually a seizure. I am going to skip benign variants because it's too great a topic, and I'm not going to do it justice. But I will give you a reference in which you can investigate benign variants on your own. How do you actually score abnormal activity? As I mentioned, it oftentimes looks like K complexers or slow waves. It's really high in amplitude. If we look at this particular epoch, all of this activity is higher than 75 microvolts. Some of it's in the slow wave frequency. It's important to note that abnormal activity does not count. These slow waves do not count towards the scoring of N3 sleep. So you would not, this spike wave waveform right here, you do not use this slow component towards the calculation of the 6 seconds or 20% of slow waves necessary for the scoring of N3 sleep. Really, it's impossible to score. You can't see slow waves, you can't see spindles, K complexes. They're often obfuscated by these interictal discharges. When I asked the former ASM Gold Standard panel scoring chair, he said he wouldn't even try. And that's the best advice he gave me. But I really want to know, well, what do you do? If your lab has the option in SleepWorks, certainly we have the option of changing to the pediatric scoring set. So we'll score that as either non-REM versus REM if there's clear differentiation between REM sleep, as we saw. REM has a protective effect against abnormal activity. So oftentimes we can still recognize low amplitude mixed frequency. We can see that drop in Chinny MG. So you might just score it N, as we did in that case, when it looks like high amplitude activity and lower amplitude activity as REM, and then wake when the patient's moving and the eyes are open, or more frequently just even non-REM versus wake. If they appear quiescent and their breathing is the infant scoring set, right? You use the eyes, the breathing, the behaviors. If they look quiescent, non-REM, if their eyes are open, and they're likely to be awake. Okay, so this is the question that was posed before. So how do we intervene when something like that happens? What happens when a patient has a seizure in your lab? Of course, remain calm. Before the study, of course, familiarize yourself with anti-epileptic medications. The patient might not tell you they have a tendency towards seizures. So if you notice that they're on some anti-epileptic medications, maybe you can ask them about their seizures. When was it diagnosed? Is it controlled? Do you have seizures often? When was your last seizure? How does it usually manifest? That's really important for you to know, right? If they all of a sudden sit up screaming and they know they have frontal lobe seizures, then you'll okay, that's what his frontal lobe seizures look like. Or if they say, well, my hands kind of jerk sometimes, you'll know that they're having a seizure. Of course, know the common triggers: sleep deprivation, of course, as we saw, or sleep fragmentation, alcohol intake, stress, OSA, and as we said, photosensitive patients. So this is the key here. So we want to know whether it's an emergency or not. And a seizure is an emergency if it's a convulsive, so that tonic-clonic kind of behavior that we saw that lasts longer than 5 minutes, or if there are repeated seizures without regaining consciousness. That's a status called status epilepticus. And that's when you want to call the code or call 911 to have them respond, because it can be life-threatening. The patient could stop breathing and in fact die, as we saw. So what do you need to do? Make sure you have good communication with the other techs. Let them know what's going on. Be reassuring to the patient, comforting, stay calm. Make sure you're tracking and recording the time of events and note as much detail as possible in terms of the description of the movements and so forth. If they're having a tonic-clonic seizure, you might want to do the basic first aid of recovery position, removing any objects near the patient, protecting their head with pillows. Do not restrain them. Do not put anything in their mouth. Keep the airway open and watch their breathing. And stay with them until fully conscious. And of course, let the fellow or MD on call know. In the case of our nocturnal frontal lobe epilepsy patient, I probably would have gone in and just made sure that the patient wasn't going to progress in terms of their movements. As Barry said, maybe gone into a tonic-clonic seizure. Ask them if they were okay. Assess what their awareness was, because if you don't get a sense that they're aware, it's a very strong indication that they're having a seizure. So hopefully that answered that question. Okay, Kevin already talked about parasomnias. I just want to end with this further reading. If you want to know any more about this topic, I've largely done most of this through self-study, just taking an hour or two every week to look up a reference on abnormal EEG, seizures, and so forth. There's a lot of YouTube videos that are out there that are helpful, but this particular reference I found very good. Eric St. Louis and Lauren Fry are the editors, electroencephalography. And it's everything you want to know in terms of the normal and abnormal findings in adult children and infants. And I think there's 5 minutes left. If anybody has any questions, I'm happy to take them. Oh, there's some chats here. Does that cause any possible injury? For example, tongue biting. In tonic-clonic seizures, that can happen. As far as I know, again, I'm not an expert, nocturnal frontal lobe epilepsy. Sometimes it can be a little bit more bizarre than we saw in our particular friend, and it can be associated with jaw clenching and really like forceful tonic posturing. So there is a potential injury in those patients as well.
Excuse me, can we catch the petit mal or absence seizure during the sleep?
Well, there might be some interictal discharges that you might see. It's unusual to be able to notice the absence seizure because really they're kind of like drop attacks, right? So you'll see like drooling and a staring and those sorts of behaviors. So as far as I know, it would be difficult to recognize them in sleep because they more manifest themselves when awake.
And if any patients comes with the history of this kind of seizure, I mean petit mal, is it logical to ask for seizure montage?
Well, that's a good question. Usually it's indicated prior to whether or not to do a full EEG montage or a bilateral montage. And it would be important to do that if you were interested in localizing the seizure. For example, in terms of frontal lobe seizure activity during sleep. It's not necessarily that useful to EEG people for us to tell them, hey, I found some interictal discharges that were isolated. We saw like maybe 2 spiking waves during the night. They're not really that interested in that. So it's less useful for them, and they probably would want to do a full EEG montage if the patient was having recognizable seizures that perhaps were recurrent or uncontrolled. So if they're having some really periodic activity, it's not really that useful for us to localize it. They're probably going to want to do their own extended monitoring EEG. But in the case of some labs that do have a neurologist on staff, they might indicate that. It's not really typical for us to do that at Sick Kids. We'll do maybe 1 or 2 a year. And that's really if like the patient is coming from far and we're doing a sleep study anyway. So we'll just piggyback, a full EEG montage on top of the sleep study instead of having them do both tests. So I hope that answers your question.
Yeah, thanks.
I'll just make a comment there too, because keeping in mind that, as Colin said, you get 0 training in EEG until you sort of seek it out. And specialists come into sleep medicine and pediatric sleep medicine from different specialties. So there are the neurologists who come, but for people like me as a respirologist, we are not neurologists. We are not specifically trained in EEG. All the EEG we learn is within our kind of sleep fellowship or sleep training. So typically we'll be very careful with people referring to us for ruling out seizures. We would recommend that be done with a kind of neuro focus, either with a neurologist or, with input from a neurologist. So we wouldn't really generally consider it a good method of investigating a patient, to look for seizures while having a sleep study. If there is really a kind of clear concern about seizures, that's kind of better worked up through a neurology pathway. Any other questions or comments for Colin?
If anybody, something occurs to you later, don't hesitate to email me. That's my email address there. I'm always happy to answer any weird questions that fellows might have.
I was going to make a question, but you answered it right in this last slide because I certainly appreciate on my 8th, 9th, 10th study when my eyes are starting to blur, our scorers or technologists flag up abnormal EEG, and it gives me a prompt to maybe look at it a bit more closely. And I know a lot of labs, some physicians may not actually review the raw data, so they may not actually be reviewing the EEG, and they're kind of depending on their score or other people to flag up if there is a concern. So on your point on education, I'm just curious, you've obviously listed a good resource here, and maybe you can provide some other good resources. But I'm wondering if you want to just make a comment on the technologists, being, and the scorers being aware and how to seek out that knowledge and education like you did.
So just how, sorry, there was a lot of comments there. So how for technologists to find these resources? Is that what you're asking?
Yeah, like, for technologists and scorers, what would you recommend beyond this resource here in developing better expertise in identifying abnormal EEG?
Yeah, sure. Well, it's very similar to say when we were prospective sleep technologists. There's a reading list on the Board of Respiratory Technology, Polysomnographic Technologists website in terms of self-study and preparing for that exam. There's a similar list on the ASAT website, the Association of EEG Technologists. So that's where I went. I wanted to know what they were what their reading list to prepare for their exam is, and that's where I would go for sure. I could find that link and send it to you guys if you want. Does that answer your question?
That does, yes. I think hopefully our techs and scorers are becoming more aware of this because we do appreciate when they flag it for us to review. With that, I think we'll let you go, Colin. Thank you so much for your talk and that really interesting topic. Maybe we'll have Katavi set up and give her talk next.
Thanks, everybody.